Gad, thank you very much, and thank you, Christian, for the very kind invitation. I'm privileged to take part in your excellent meeting. This slide is my declarations. I don't have any conflicts with regard to this presentation. So, the question that I've been asked is who needs intervention in 2011? And what I'm going to do is to try and sum it up in one slide, the challenge. This is a real cross-section of a patient's coronary artery. And at the time that the patient first developed atheroma, this is stage 1 in this, he did not have any obstructive lesion and he did not have angina. At the second stage, he developed an acute coronary syndrome and probably a shower of emboli. He had angiography and he did not have an obstructive lesion. Despite being on secondary prevention, over the course of a decade, he then had plaque growth, which is number 3. And finally, he died a sudden death before the emergency medical system reached him because of an arrhythmia. So here's our challenge, that we're dealing with a continuum of progression of coronary disease. I'm going to take it as an abundant evidence base for intervention with percutaneous coronary intervention in acute ST elevation MI, and I'm not going to discuss that further. I am going to discuss non-ST elevation ACS and stable angina. So really what's important is not just the angiographic appearance as you'd get from syntax, but also the clinical setting. And this patient could have acute coronary syndrome or stable angina, and the implications are different. And let me just stress some of the differences in outcome. Here are event rates in various studies of stable ischemic heart disease, and then I'm going to add in the non-ST elevation ACS. And you can see in the stable ischemic heart disease, the average event rates at 12 years, death or MI, was about 1.5%. And please look at the contrast with the FRISC-2 trial after ACS, where the event rates, as you know, were much higher. And that's where courage lies. People have criticized courage as being low event rates, but actually, the event rates are higher than in many prior studies of stable coronary artery disease. Now let's consider the studies that were done prior to courage. This is PCI versus medical therapy and a meta-analysis of 11 randomized trials. And the answer is there is no significant difference. The confidence intervals all overlap unity. So no definitive result. You've heard about the courage trial, and PCI did not reduce death or MI in stable ischemic heart disease patients. And here is the summary slide. Also the Barry 2D study, and this is the survival in revascularization versus medical therapy, which was no different in Barry 2D. And you've heard the elegant analysis from Christian Ham of syntax, showing here the superimposition of the rates of death from any cause, stroke or MI for PCI or CABG. And repeat revascularization was more common with PCI, and stroke was more common with CABG. So, here's the question. Do we take courage post-courage? In the UK, we were designing the RITA-4 study, and we've merged that with the ischemia study. I'm going to be talking about that a little bit. There are some issues to consider. In courage and in Barry 2D, randomization occurred after cath. So that means some of the most suitable patients were selected out. And this may not be a comprehensive analysis of all the patients that were available. And you've seen the synopsis of the nuclear sub-study of Courage, but I want to emphasize that is only 200 patients. So there were 105 patients with moderate to severe baseline ischemia who returned for a second study. And here we see this is with PCI reducing ischemia by 78% of the time versus medical therapy reducing ischemia half of the time. And in both groups, if one has ischemia reduction, there is better outcome than if you do not have ischemia reduction. So, does PCI reduce events? There's a problem. Routine revascularization for anatomic or physiologic stenoses, and the relation between angiographic severity and propensity to become a culprit lesion is complex and non-linear. Obviously, we know that atherosclerosis is a systemic disease with diffuse involvement not only in coronary but also systemic disorders. And we know that since some of the trials, medical therapy has changed outcome. This is an electron micrograph of a coronary artery. And it's a coronary artery in someone who died an incidental death. And the bad news for those of us who are male over 45 in this room and women over 55 in this room, that we probably have a plaque erosion or superficial rupture like this at the moment in about 8 out of every 100 of us at the moment. So I hope you enjoyed your coffee break and what you ate with your coffee break. And the proposal that I'm putting to you is that rather than plaque rupture being a rare and devastating event, it's actually common. It's common, but mostly we heal these superficial erosions. And the balance between progression and repair is modifiable. And Mike Davis and Erling Falk did studies of people who had incidental deaths. These individuals were the passengers of road traffic accidents, not the driver, the passenger. And at the time of their death, not caused by the accident, they had incidental erosion or superficial rupture in about 9 out of every 100 and about 16 out of every 100 if they happened to be diabetic or hypertensive. So this really tells us that erosion and rupture are not rare events. And this fits in with what you've heard from Harvey about being able to detect the consequences of such erosion events with very high sensitivity troponin. Now, what about ischemia? The ischemia trial is going to be a challenge. It's a large international trial, and we're delighted that it has now been funded by the NIH in patients with at least moderate ischemia and an ejection fraction greater than 35%. And the hypothesis is that an initial invasive strategy of cath followed by revascularization, and that's either PCI or CABG, depending upon what is appropriate for the patient, on top of optimal medical therapy, is better than optimal medical therapy alone. And these are in patients in whom there is a significant extent of myocardial ischemia. And here's the primary endpoint. And you can see that there are secondary aims within the study, 8,000 patients over 4 years. So it's really quite a challenge. And they require about 10% of the ventricle to have reversible ischemia by one of the non-invasive diagnostic tests. And this is the algorithm that we'll use in the ischemia study. So it's the eligible patients, informed consent, enrolling. There's a blinded CT coronary angiogram to exclude left main disease, and the randomization here. And you can see the information, and there will be the use of the FFR in this study. So that's a little bit about the challenge of stable coronary artery disease and us not assuming that everybody's in one basket, but perhaps those with large residual ischemia need to be managed differently. What about those with non-ST elevation ACS and needing intervention? Well, there are many colleagues who say troponin and clinical judgment is just fine. We did this analysis, the study with Gabriel Steg and some colleagues, and please look at the distribution. This is from our very large GRACE study of 27,000 people. Please look at the distribution here in yellow of those who presented with a clinical syndrome of ACS and the initial troponin was negative versus those that were positive. The answer is, as you'd expect, the curves are shifted to the right, but there is substantial overlap. And please note that the risk of mortality is rising very steeply out here. So my message is that yes, troponin is positive, but we should not adopt a binary approach to say troponin positive, troponin negative. We really need to consider the other risk characteristics. Let me illustrate this. We published this information some time back, and it's been validated in a Canadian study. And I'm showing you the Canadian study. This is looking at the assessment of risk in these patients. And the Canadian investigators, who are very experienced, were asked to assess, in the physician's estimate, what the risk of the patient was and link it to the frequency of revascularization and cath. And their estimate was, in those that they thought were lower risk, they were getting less cath. In those that they thought were higher risk, were getting more cath. So that seemed absolutely fine until they actually measured the risk, and it was the inverse. What they actually measured and found was that those who were getting the most caths actually were the lowest risk, the most interventions were the lowest risk, and the converse true for the high-risk individuals. So the message here is, standing at the end of the bed and just using one marker is insufficient. If you systematically use a risk score, you're going to get a more comprehensive analysis of what the risk is in that individual. How are we going to identify the vulnerable patient? It's beyond the scope of this lecture to go into all the aspects of clinical phenotype, the systemic markers, and the forms of imaging and genetic markers. But I just want to highlight a couple of things out of interest. We asked the question about whether a specific genetic marker would add to the clinical phenotype. And we know that the phenotype characteristics are highly powerful in predicting death. In our 42,000 patients where we developed it and then validated the score, the C index was 0.82 for death, which is pretty good. But it's very weak at predicting recurrent MI. So our clinical phenotypes are not so good at predicting recurrent MI. And what we did is we've analyzed the impact of the 9p21 locus in a particular variant. And this was associated with atherogenesis in 4 independent genome-wide association studies with an odds ratio of about 1.25. So you'd expect that a single gene has a rather modest effect, but consistent across several studies. And it's highly likely there will be multiple genes that are influential. But this is a frequent risk variant, and the population attributable risk is not trivial, 20 to 30%. And it's associated also with peripheral artery disease, diabetes, and aortic aneurysm. And what we did is we took the population in southeast Scotland, the population in Belgium, and in Poland from our large prospective study over the course of 5 years of outcome. And we looked at the impact of the risk variant on top of the clinical risk predictors. And the answer is that, well, first of all, the hypothesis was that the gene variants would be associated with acute coronary syndrome, not just with atherogenesis, which is what been shown before, and be associated with recurrent plaque rupture and MI. Now, this was a tough bar, because we already know that this population is enhanced. We asked whether they would be likely to get recurrent MI within 6 months. So that was a very tough bar. And the answer is yes. This was associated with acute coronary syndrome, and it's not trivial. We're talking about 4 times 10 to the minus 5 for a p-value. The odds ratio of 1.2, which is roughly what we'd expect, and it was independently validated in 2 separate populations, and it was independently associated with recurrent MI. Am I saying this is the only predictor? No, but we do need to consider the interaction between the genotype and the phenotype. And this shows you the difference between having either being a homozygote or heterozygote for this allele versus not at all. However, there's a problem. And my colleagues turned around to me and said, how on earth can this work? We usually look at the flanking genes to get a hint at what it does. And this particular variant was located in a gene desert. So how on earth could it work? Well, very interestingly, published just a few weeks ago in Nature, was some elegant work from University of California, San Diego, showing the way in which this particular gene variant has a remote amplifying effect on interferon gamma and STAT1, both pathways in terms of inflammation biology important in plaque rupture. Have we reached the limits in identifying these plaques? No, we haven't. There are elegant ways that we can do this, and at the moment we're doing studies in our center over the last couple of years with 320 slice CT, and this is from one of our research fellows who's looking at the distribution of lesions in the coronary artery. And this is with alteration of the Hounsfield units to show the differences in plaque characteristics with this very high resolution CT. And indeed, here's a 10-year study after multi-slice CT. What about short and long-term outcome? Well, we believe in the European guidelines. And the European guidelines showed us that at a year, in non-ST elevation ACS, there is a benefit for a strategy of intervention. And the answer is the absolute benefit in terms of death MI was 1.6 per 100. So relatively modest, but significant. And when I presented the 5-year outcomes, the commentator at the ESC in the hotline session was Freek Wegert, and he said to me, or he said to the audience, that performing PCI is like having sex. Everyone likes doing it, but nobody cares about the late results. Well, perhaps we do care about the late results, and we should. And the late results are important. What is truly remarkable is this is from our all of the randomized trials that have been done with 5-year follow-up. This is from our own RITA-3 trial, from the FRISC-2 trial, and from the ICTIS trial. So this is all of the available data over 5 years, and it's an individual, patient-determined meta-analysis. And the hypothesis was that the ongoing disease was such that the curves would come together over time. And truly remarkably, randomizing to an interventional strategy here still has an impact 5 years later. We're not talking about relative risk reductions. We're talking about an absolute risk reduction here of 3.2% at 5 years. And if we divide the population according to risk, it's very interesting. If you're in the highest risk tertile or core cohort, the absolute difference here is 11%. That's not relative, that is absolute difference. And it's not in a soft endpoint, it's cardiovascular death or MI. Even if you're in the moderate risk group, it's 3.8%. And you tell me a pharmacological study that has achieved 2% absolute benefit in terms of cardiovascular death and MI at 5 years. I don't know of one. So remarkably, there is sustained impact. We've also reported that the late consequences of acute coronary syndrome are underestimated and under-recognized. In cardiology, we focus on the patients when they're in our acute care units, and we focus not enough on the late consequences. We've analyzed 5-year outcomes for our entire cohort, and it was comprehensive. Out of 3,500 patients, because of the record linkage system we have in the UK, there were only 4 patients missing. And you can see that for ST elevation, 19%, despite all the secondary prevention, non-ST elevation ACS, non-ST elevation MI, 20%, and unstable angina with other evidence of coronary disease, almost the same. Most deaths are after hospital discharge. So the answer, my friends, is we're concentrating on the wrong period. Here's the distribution of events. Please look at the number of individuals who have 1 or more myocardial infarction, 1 or more revascularization, 1 or more stroke, and 1 or more admission to hospital with an acute coronary syndrome with an ECG abnormality over the course of 5 years, about half of this cohort. What about improving medical and interventional therapy and outcome? We've analyzed in the GRACE study over the course of 7 years that there was no change in stroke rate. Perhaps the most striking and remarkable change was the decrease in new heart failure. This is heart failure that was not present when the patient arrived at hospital and independently demonstrated with radiological evidence. So over the course of time, the improved therapy has resulted in a decrease in heart failure, a decrease modest in deaths and in cardiogenic shock, but most striking in heart failure. I'm now going to show you a couple of slides from the MINAP dataset from the UK. The MINAP dataset is from every patient admitted to every hospital in England and Wales. And the reason it's comprehensive is because it's government funded and the hospital does not get reimbursed if they don't enter the data. And please note that the median age is not in the low 60s, as in some surveys, but 74. This is and there are 750,000 records in this comprehensive data set over the course of this time. And this is the use of the secondary prevention measures on discharge, which is pretty high. Remarkably, the rates of mortality following ST elevation MI have been falling progressively, a 33% decline over this time period. Remarkably, in non-ST elevation MI, there's an even more marked fall in the rates of mortality. This is 30-day mortality. And this is 6-month mortality. So the question that arises is what's doing this? And in an analysis that we have not yet published, but I will be, is asking the question, is this just because of the fact that we are treating less ill patients now than we used to treat? So we analyzed the outcomes in non-ST elevation MI for the 6-month outcomes, adjusted for comorbidity. So it's comorbidity, the Grace risk score, previous angina, hypertension, hyperlipidemia, diabetes. And the answer is, despite these adjustments, outcomes have continued to improve. And now, very interestingly, if we adjust for intervention on top of this, the benefit disappears. Very interesting and provocative. So my conclusion is, in trying to address the question, who needs intervention in 2011, ST elevation MI clearly is abundant evidence for primary PCI. And in those who still get lysis, there's evidence for post-lysis angiography PCI. In non-ST elevation ACS, in those with moderate or higher risk, clearly very strong evidence. And there is more modest evidence in those with low risk and ischemic burden. In patients with stable angina, obviously there's a role for symptom relief. In patients with stable angina for prognosis, no. As of now, we don't have the evidence. In patients with stable angina and large ischemic burden, perhaps, and I hope that we will answer that after the ischemia trial. And we must, in the meantime, remember late outcomes and maintaining secondary prevention. Thank you very much.